Well, hello and welcome to Pharmacology for Practicing Nurses. This is one of my favorite courses. I am really very excited to have everybody involved, and it is my genuine hope that when you come out of the course, you have a better understanding, a higher level understanding of pharmacology with particular respect to how drugs work. I just am a really firm believer that if patients understand why we are asking them to take the things that we take, like why any given drug is the right thing for them and their disease, the patients are they're much more likely to do it. They're more likely to be adherent, just like any of us as adults are more likely to do a thing when we understand the reason for it, rather than just having somebody give you something and say, here, you need to do this. All of us want to know why. So a big part of this course, my hope is that when you finish this course, you will have a much better understanding of the why, and you can take a little time to explain it to the patients. I mean, I'm a realist. I know that time constraints are always huge, and none of us, rarely do any of us have time to sit down for a half an hour and talk. But even 2 or 3 minutes can be a very long time if you have really good substantive information to give. So anyways, I know I probably said all of that in the audio syllabus. Here we are for week 1, and Weeks 1 and week 2 actually are also they're the foundational pharmacokinetic kind of stuff. Not always the most fascinating, but they provide the foundation for understanding the rest of it. So if you will bear with me and we get some of these, terms really down, then everything else is just a little bit easier to understand. So this is Pharmacokinetics Part 1. Next week will be Pharmacokinetics Part 2, and then we actually really will get into body systems and disease and drugs and how they work. But right now we have some theoretical constructs to talk about. So, like any science, there is a theoretical foundation, and in pharmacology, the theoretical, or one of the theoretical foundations, is receptor agonist theory. And this is important to understand. Of course, I'll say everything's important. I guess it wouldn't be in your slides if I didn't think so. But this really is the foundation of why we give what we give. It's receptor agonist theory. So, like your slide says, pharmacologic agents are either an agonist or an antagonist. Almost without fail, every drug that you give to somebody functions as an agonist or an antagonist. So logically, it makes sense to understand what they are. An agonist binds to a receptor on or within the cell and produces some sort of biologic response. Remember, the cell is the smallest independently functioning unit in the body. Most cells have a nucleus. Excuse me, most cells have a nucleus, they have organelles, they are self-encapsulated by a membrane. They're the smallest functioning independent unit in the body. So if you want to effect a change in something, as we typically do when we're medicating a disease, you've got to get at the functioning units. So an agonist binds to a receptor somewhere either on or within the cell and produces a response of some sort. It actually makes a change. It makes a change in the function. Conversely, an antagonist binds to a receptor on or within a cell and blocks the action of an agonist. Antagonists have no inherent action on their own. All they do is block something else. Now, both agonist and antagonist occur naturally all the time, like every day. Agonist and opposing antagonist reactions are occurring in the body. But with pharmacology, when we give somebody a drug, that drug is acting either as an agonist to produce a response, or it is acting as an antagonist, which doesn't do anything on its own, but it blocks some naturally occurring phenomenon in the body. The receptors that these antagonists bind to can be located anywhere in or around the cell. Sometimes receptors are enzymes, and these are compounds that serve to facilitate or produce a response. Enzymes typically are regarded as accelerating a response in the body, and sometimes the receptors themselves, or sometimes the enzymes themselves are the receptors. Sometimes receptors are nucleic acids. They are right on the DNA. Remember, DNA is contained in the nucleus. It's kind of like command central for the cell. The master code for everything that happens in the cell is contained on the DNA, and the DNA is comprised of nucleic acids, and sometimes receptors are right there in the nucleic acids. So an agonist or an antagonist binds directly to a receptor right on the DNA to make things happen or block things from happening. And sometimes the receptors are actually embedded in the cell membranes themselves. So, I mean, the real point of this slide is that the receptors are like a lock mechanism. Receptor agonist theory is like a lock and a key, right? You have, or, better yet, let's say, well, no, I'm getting all excited with my analogies, and they probably won't make sense. We'll just stick with the lock and the key. I didn't make that one up. That one's universally used. So you've got a lock, which is a receptor, and the key is the agonist. And the key binds the receptor and makes something happen. In some cases, a block sits on top of the receptor and keeps the key from working. Maybe you got a child-proof thingy in there. I don't know. But the receptor is what we're talking about, and receptors can be anywhere. They can be on the membrane itself, embedded into it like a membrane-bound protein. They can be well inside the cell, right on the DNA, or they can be enzymes that are embedded in the cell or encased in the cell and doing a job. That's the point here. So this is a picture of a cell membrane, right? So I'm going to try to use my pen function thing here. So the whole thing is a cell membrane. Remember that the cell membrane structure that you learned about sometime back in Biology 101 is that cell membranes are made of lipid bilayers, right? You have the hydrophilic heads right here, and then the hydrophobic tails. And it's a bilayer. There's two pairs of them. You've got the pair that's on the inner surface of the cell membrane, and then the ones on the outer surface. And these, collectively, this whole thing creates a lipid barrier that separates inside of the cell from outside of the cell. Because intracellular fluid and extracellular fluid are water, right? And the membrane is a lipid, it's a fat, and it very effectively separates those two water components. The only way for something to get from the outside of the cell, like up here, to the inside of the cell, down here, is to be able to cross this barrier, to cross this lipid membrane. If the substance is a fat, then the fat can just diffuse right through the membrane because fat will melt into fat. But if you have a substance out here, and it can be a naturally occurring substance or a drug, I mean anything, if it's water soluble, if it's watery, and it wants to get from here to here, it's got to get through the membrane, through a channel or a receptor of some sort. So some agonists or antagonists, their job, now I'm going to get fancy here and change the color, they bind to these receptors right here in the membrane and then affect a response. I'm probably making this harder than it has to be, right? I'm sure you're with me so far. This gives you an example of a receptor and an agonist. And insulin is a great example because it's one that we're all familiar with. We talk about it all the time, right? So again, here you've got your cell membrane. Forgive me, I'm trying to learn how to use this thing. You've got your cell membrane, and then embedded in the membrane is this membrane-bound receptor, the insulin receptor. And in order for the cells to be able to uptake glucose and store it, insulin has to bind to the insulin receptor. Insulin is water soluble, so it just can't cross the cell membrane and do a job on its own. The insulin binds to the insulin receptor, and when that happens, it makes things happen within the cell. And now you can see that as a function of this binding, and then what I'm pointing to here is the receptor with insulin bound to it. Now stuff happens. And among that stuff that is happening in the cellular response to insulin is that now glucose can go into the cell. Glucose may be burned as fuel. It may be stored as glycogen, but the bottom line is it can get inside. This is what happens when a receptor binds, when an agonist binds to a receptor, you get a response of some sort. So agonist and agonist receptor union produces a biologic response. An agonist can be anything. I mean, it is any compound, either one that occurs naturally within the body like insulin, or exogenous, meaning some external thing that we introduce to the body. The agonist then binds to the receptor and produces the biologic response. It can be either endogenous or naturally occurring, or exogenous, which means usually it's a drug. and we give it. And when the agonist and receptor come together, you get this response. Increasing the amount of agonists will logically increase the biologic response until either maximal response is reached or until all available receptors are saturated. And the difference between these two circumstances is that sometimes you will get a 100% response and sometimes you won't. We refer to as a 100% response as a full agonist response. And in a circumstance where an agonist is introduced in the very highest possible amounts and it still doesn't produce completely the response that you want, then we call it a partial agonist. And the next slide gives you some examples. Okay, so for example, if you are treating it as asthmatic and the patient comes in having an acute asthma exacerbation and you give them albuterol or some, form of albuterol, like there's several different brands, but they're all generically albuterol. Remember, albuterol is synthetic epinephrine, right? So when you give an asthmatic albuterol, you are giving them the agonist epinephrine. And the agonist binds to beta receptors, beta adrenergic receptors in the bronchial smooth muscle and causes bronchodilation so that the patient can move air more efficiently and stop wheezing. If you have a patient and the patient's having an asthma exacerbation and they're wheezing and short of breath, and you give that patient an albuterol treatment and the patient completely relaxes, the wheezing is gone, and they feel like they can breathe normally again, this is a full agonist. You got a 100% response. And it always surprises me when this actually happens, but honest to goodness, just less than 2 weeks ago, at either this week or last week on my day in the clinic, I had a young boy. I see patients as an outpatient, and I had a young teenager walk in and actually I guess he's 18 now, so he's not that young, but he was having an asthma. He's been a brittle asthmatic. He's been really hard to control, never takes his controller medications. But he walked in, he couldn't breathe. He's coughing, he's wheezing, he's bronchospastic, and he can't breathe. He needs to be seen, emergently. So I bring him in, hear that he's wheezing, sit him down and give him one nebulizer treatment. Really not ever expecting that one treatment would make all the difference in the world, but gave him the treatment, walked back in 5 minutes later. He's just sitting there. He's not coughing. He looks fine. He says he has so much more energy. He feels great. He can breathe deeply now. And I listened to his lungs, and I mean, really, there's not any real wheeze to speak of. Maybe one little faint wheeze, in several auscultations. So this was a 100% agonist. We got the complete response we were looking for. That's a full agonist, and sometimes that happens. Conversely, sometimes you will give as much as an agonist as you can give. Sometimes you give as much of an agonist as you can give, and you can't give any more because it can have some unsafe phenomenon, like the next bullet point example here. Or sometimes you just give so much, excuse me, and it reaches what we refer to as a dose ceiling, where basically all receptors are bound and it's just not giving you the 100% response you look for. This we call a partial agonist. So the example that's given here is you may have a patient who is having profound pain, and you give the maximal safe doses that you can of any given opiate. And when I say maximal safe, I mean typically that it's getting to the point where you're worried about suppressing respiration, you're worried about the patient's mental status. You've given as much as you can, and you still don't get pain completely blocked. This then is a partial agonist. One example of this might be somebody who's having profound they had a major operative procedure, maybe like a bony procedure, a reduction of an open femur fracture or something, and they're just in such profound pain. You give them the max doses of Dilaudid you can, and you never completely get the pain under control. Maybe you take it down from a 9 to a 3. I mean, that's going to be enough to get the patient through the day, but it's not a full agonist. It didn't completely reverse the pain. So that's the difference between a partial and a full agonist if you hear those terms. Antagonists, remember I said, have no inherent effect of their own. When you give an antagonist, it doesn't do anything to the patient. All it does is block the effect of an agonist. In pharmacology, typically we give an antagonist to block the effect of a naturally occurring agonist. So we've established that, right? The presence of an antagonist makes an agonist less potent. For example, these are all antagonists that we use routinely in pharmacology. Beta-adrenergic receptor antagonists. I'm sure you're familiar with them. We use them all the time to manage coronary artery disease. In fact, they're the drug of choice for patients with coronary artery disease. Tenormin, low pressor, Coreg, propranolol. These are beta-adrenergic receptor antagonists. They don't do anything on their own. What they do is block beta-adrenergic receptors. So beta-adrenergic receptors are receptors they're dispersed all over the body. But when we're giving patients beta blockers, what we're trying to do are block the beta receptors in the heart. And many beta blockers or beta-adrenergic antagonists, we generally call them beta blockers, they're cardioselective, so they just target beta receptors in the heart. For instance, atenolol, which you know as tenormin, and metoprolol, which you probably know as low pressor. These are cardioselective beta blockers. They only block beta receptors in the heart. So they don't have any effect on their own. What they do is block the action of epinephrine. Epinephrine is a naturally occurring agonist, and when epinephrine binds to beta receptors in the heart, it increases the force of cardiac contraction and can increase heart rate. And at any given time, like all of us, have some epinephrine acting on the heart to some extent, which helps regulate our rate. If you have a patient who has coronary artery disease, then that patient, we need to reduce the workload of the heart. We don't want it working as hard. So a very common drug strategy is to give the patient a beta-adrenergic antagonist or beta blocker, block some of the beta receptors in the heart so that you block the action of epinephrine. The epinephrine can't do anything, and so ultimately it decreases the workload of the heart. Now, that's the upside because you want to relax the heart so it doesn't require as much oxygen. The downside then is the heart is not capable of having a reaction where it can beat harder or it can beat faster. So like if you suddenly have to run, you're going to miss the bus and you have to start running down the street. Normally when you run, you will have a little epinephrine surge so that epinephrine can bind to beta receptors in your heart and make it beat harder and faster to get more oxygen to your brain and vital organs, which supports you while you're running. Well, if you take a beta blocker, you're not capable of doing that as effectively. So some of your compensatory reactions may be a little bit impaired. But for a patient with coronary artery disease who needs to rest their heart, the risk-benefit ratio favors doing it. In other words, if you have heart disease and you need to relax your heart, we're going to give you a beta blocker. We're going to block the action of epinephrine and give your heart a break and relax it. And then if you have to run, well, expect it not to be as efficient. Expect it not to be as easy. Makes sense? I mean, that's the whole idea here. So really, I mean, the impression I want to leave you with this slide is that an antagonist doesn't have any action of its own. It blocks the action of an agonist. And in pharmacology, typically when we give somebody an antagonist, we are blocking the action of a naturally occurring agonist. Another commonly used antagonist we use in pharmacology are angiotensin II receptor antagonists. You would probably know these as ARBs, ARBs, that's what we call them. And angiotensin II is a naturally occurring compound that binds to angiotensin II receptors and does a few things in the body. But the one we're most familiar with is that it causes vasoconstriction of arteries and can raise blood pressure. And at any given time, you have several different things going on in the body to raise your blood pressure, and one of them is that angiotensin II is binding to angiotensin II receptors. That's why one of the ways that we treat hypertension is to give the patient angiotensin receptor blockers, or ARBs. When we give these drugs, it blocks angiotensin receptors, doesn't allow angiotensin II to bind to it, so it blocks one of the triggers that causes vasoconstriction. That way the vessels stay more dilated and blood pressure doesn't go up, and it keeps the patient's blood pressure down. So agonist, antagonist. This is receptor agonist theory. This is the underlying theory of pharmacology, and it's what these first 10 or 11 slides, lay the foundation. I really just want you to understand what we're talking about here, because all the time in pharmacology, we talk about agonist and antagonist or blockers, and hopefully now it makes a little bit more sense. So the last slide on this topic is the picture slide. Here we go. So, okay. So this shows you the difference among antagonists, the difference between a competitive and a non-competitive antagonist. Oh, I'm sorry, I didn't, your last slide introduced this, and I just went off on a tangent and didn't spend much detail in it, so I will now. So in the world of antagonists, we have two general types, competitive and non-competitive antagonists. So competitive antagonists bind for the same receptor site as the agonist, and that's what this is trying to show you. So this slide is showing you one pair. Let me draw a circle around it so you see what I'm talking about. Okay, so this is example number 1. I'm getting better with my circle drawing. What this is showing you is, first you've got a receptor that is embedded in the cell membrane. Here's your receptor. And in this picture that I've encircled, you have an agonist, a naturally occurring ligand. I mean, remember, in science you have 5 different names for everything. Ligand is the same thing as an agonist. It's something that binds to the receptor and causes a response. So in this case, you have some naturally occurring ligand. Let's say epinephrine, naturally occurring epinephrine, and the epinephrine, which is right here, binds to the receptor and will cause a response. In the heart, it will cause increased heart rate, increased contractility. This arrow is showing you what this receptor looks like after it's been activated, after the agonist binds to it. So this is the receptor in an inactive state. This is the receptor once the agonist is bound to it, right? Receptor agonist theory. Now you're getting a signal. Now, how an antagonist works, there are 2 different approaches. In some cases, you have competitive antagonist, and that's what this picture is. So in this picture, you see the receptor, again, right here, and you know where the agonist wants to bind. The square wants to fit in the square. But in this case, you have a competitive antagonist. Now, in this case, we'll say it's tenormin. We want to block the action of naturally occurring agonist. So we give a competitive antagonist which competes for the same point in the receptor, the same binding site right here. And now you see what happens when this competitive antagonist has gotten in the way of the binding site. Obviously, the agonist can't bind, and you will get no signal or no response. So in this case, the tenormin bound to the spot, the epinephrine can't get in there, and you get no increased contractility in the heart. That's a competitive antagonist when the antagonist competes for precisely the same binding spot. Now, another type of antagonist are the non-competitive antagonists, and that's what you've got down here. So again, you've got your receptor that's embedded in the membrane. You've got an agonist that wants to bind right here. A non-competitive antagonist will bind to the receptor in a different place, in its own binding site. In other words, it's not competing for the binding site like the last example we talked to. So what you get is the end result is you get a partial blocking or a partial blockade of the signal. The agonist was still able to bind, but now an antagonist bound to a different part of the receptor and blunts the overall response that you get. You will get a partial signal. Angiotensin receptor blockers are non-competitive antagonists. So that's exactly what's happening here. You have naturally occurring angiotensin 2 binding right here, and it wants to cause vasoconstriction and raise blood pressure. But then you give the patient an angiotensin 2 receptor blocker, and it blocks right here. So it's going to attenuate or interfere with how much the artery can vasoconstrict. There's a partial signal. There will still be some constriction, but not as much as there would be if this non-competitive antagonist wasn't here. So that's the difference between a competitive and a non-competitive antagonist. And you get, it's analogous to the full or partial agonist response. When you give a competitive antagonist, theoretically, you can 100% block the response of the agonist. On the other hand, when you give a non-competitive antagonist, you're going to get some agonist responsiveness here. It's like theoretically impossible to block it 100% because you still get some agonist action, like you can see right here. Hope that helped. All right, let's switch gears a little bit and talk about some other terms. Efficacy and potency. Efficacy and potency are two terms that you will see kind of thrown around in discussions of pharmacology, and it's really helpful to understand what we're talking about because they get mixed up a lot. But they're two different things. They're both important, but they're two different things. Efficacy is the maximal response that a drug can produce. Efficacy is effect. Think efficacy equals effect. Potency is the amount of drug or the dose of the drug required to produce an effect, right? Two different things. So, efficacy basically is how well it works. And we often assess efficacy, well, there's lots of different scales, but in terms of pain, which is the example that's given here, you know the 1 to 10 scale for pain, right? We often ask patients on a scale of 1 to 10, with 0 being no pain and 10 being the worst pain you've ever felt in your life, how bad is this pain that you're experiencing? If the patient takes a medication that reduces their pain but doesn't eliminate it, well, it's getting some efficacy. And if it completely eliminates the pain, then they're getting complete efficacy, right? So like, for instance, say you get migraines or cluster headaches or some really bad headache phenomenon, and you take a medication, and the medication that works the best for you, the thing that gives you the greatest effect, can only take your pain from a 10 to a 5 on that 1 to 10 scale. Well, then that medication has a 50% efficacy. It's cutting your pain in half. If your pain started out as an 8, and you took the best medication, the one that works the best for you, and now you're down to a 4, you've, again, reduced it by 50%. So the efficacy of that medication is about 50%. Now, if you have a headache and you take a medication and it gets rid of your headache completely, then that's 100% efficacy, right? It did the job 100%. So efficacy is about how well it works. It's got nothing to do with amount of drug or dose. It's just about how well it works. All right, pictorial interlude, just in case none of you have had the joys of experiencing a bad headache. There's lots of actually better pictures than that. I like pictures that show people like that are pulling your eye out and stuff like that, because sometimes a bad headache, that's what it can feel like. But anyway, you get the idea. Potency refers to the dose of the drug required to achieve the response. So now we're talking about amounts, right? So the example given here, if 4 milligrams of morphine produces pain relief and 50 milligrams of meperidine produces the same level of pain relief, they're equally efficacious, but the morphine is more potent because it takes less of it to do the same job. All right, so let's just say, so again, I keep using the example of post-op because it's just pain that everybody understands. Suppose you have a patient who's post-op from a really painful procedure, and you gave them like whatever your maximal dose of Dilaudid is, like say 2 milligrams, or maybe you got lucky and gave them 4 milligrams. And it's the highest dose you can give because you're starting to worry about them, losing responsiveness. But even still, when you arouse them, they said the pain is better, but they can still feel it. Anyways, you don't want to give them Dilaudid anymore for whatever reason. Maybe they got a rash. And then somebody orders 50 milligrams of morphine. I'm sorry, don't order 50 milligrams of morphine. Nobody will have any pain, especially if you're giving it parenterally. Somebody orders 50 milligrams of meperidine. And they say the same thing. Well, it's still a little bit there, but it's just as good as the other medicine. It's 2 different doses giving you the same efficacy. So the efficacy is equal, but the potency is different. That probably wasn't the best example I can give you. Let me give you another one. Let's say that you have a patient who is okay, let's say you're having a headache. You've been studying too hard. You keep listening to me say the same things over and over on these slides, and you get a headache. And your answer to a headache is to take 2 extra strength Tylenol. So extra strength Tylenols are 500 milligrams a piece. You take 2 of them, that's 1,000 milligrams. It takes care of your headache completely. It's gone. It's 100% efficacy. And then the next time you're studying, you get another headache, and you're out of Tylenol, but somebody gives you some ibuprofen. And ibuprofen comes in 200 milligram tablets, and they say, take 2 of these, this stuff is amazing. So you take 2 of them, and your headache goes away completely. Both of those drugs were completely efficacious, but 400 milligrams of ibuprofen did it, whereas 1,000 milligrams of acetaminophen did it. The ibuprofen is more potent. So again, the point here is that potency is not about how well a drug works. It's about how much of the drug it takes to do the job. Potency is about what it takes to get it done. Efficacy is effectiveness. It's how well the drug does what it does. There's 100 different examples. You may have somebody who is taking, we'll say, 10 milligrams of amlodipine to get their blood pressure under control. And then that same patient can't take the amlodipine because it makes their ankles swell up and they don't like it. So the amlodipine worked really well, got their blood pressure to goal, but they couldn't take it. So then for some reason somebody puts them on hydrochlorothiazide, 25 milligrams. And the hydrochlorothiazide gets their blood pressure to goal, gets them where they need to be. Both of these drugs were equally efficacious. 10 milligrams of amlodipine, 25 milligrams of hydrochlorothiazide. The amlodipine is more potent. But really, who cares? Because like this slide says, the fact that one drug is more potent does not make it a better choice in any given circumstance. Efficacy is the quality that allows us to determine how well a drug will work. And the reason I mention this is that sometimes you'll hear people talk about how potent something is as if that's like so awesome. Years ago, there was a new headache, Years ago, there was a new headache drug available for over-the-counter, an over-the-counter analgesic that was marketed for headache pain. And it was called Arudis KT. I'll never forget it because the commercial was really catchy. You had this commercial on TV, and this big, orangey yellow O kind of rolled into the screen. It was very dramatic. The big O kind of rolled into the screen, and then the letters KT, I forget what they stand for, the letters KT swung in on the bottom, like they swished in, like a race car. And it was like Arudis KT. Something like 10 times more potent than ibuprofen for your headache pain. And it probably was, because I think it took 2 milligrams of Arudis KT. It was marketed in 2 milligram tablets, or maybe you said 100 times more. I don't remember the specifics, but you get the idea, right? They were selling Arudis. I really believe it was 2 milligrams of Arudis KT. And so they were saying 100 times more potent for your headache pain, which is true, because a 2 milligram tablet of Arudis KT would do what a 200 milligram tablet of ibuprofen would do. 100 times more potent. Sounds awesome, right? Like anybody who's ever suffered from headaches is probably going to run out and buy some Arudis KT. But guess what? It was like twice as expensive. A bottle of 100 pills of Arudis was twice as much as a bottle of 100 pills of ibuprofen. So then what you have to ask yourself is, does it matter? If the ibuprofen works and it's safe to take that dose, and the Arudis works and it's safe to take that dose, why would you pay twice as much for the same thing? Now, if it said 100 times more efficacious for your headache pain, then that would be worth doing, because that would mean it works 100 times better. But all potency means is that a lesser amount of the drug is required to do the same thing. So if you ever hear anybody telling you how wonderful a drug is because it's potent, ask them, well, does it work any better? Is it any more effective? That's the distinction between those two terms. All right, now we're going to switch gears yet again to another term, and I don't know, perhaps clinically the most important term that we'll talk about in this slide set, and that is bioavailability. Look how very dramatic. Bioavailability, a critical concept in pharmacokinetics. It is. And pharmacokinetics, by the way, I don't think I actually defined that term for you, and I probably should have, because there's a lot of different like pharmaco this and pharmaco that gets thrown around. Pharmacokinetics is what the body does to the drug. Like when you put a drug in somebody, the body's immediate response is to try to get it out, because the body doesn't like things that it perceives don't belong there, right? The body likes everything to be steady state. The body likes homeostasis. So as soon as you introduce something into the body that the body perceives as foreign or not, that shouldn't be there, it's going to immediately try to get it out. That's pharmacokinetics, basically. Pharmacokinetics refers to how a drug is absorbed, distributed, metabolized, and excreted. And so pharmacokinetics, I mean, of course we have to consider it when we're talking about safety and interactions and how it works. Pharmacodynamics, which we'll talk about like from week 3 forward, pharmacodynamics is what the body does, or what the drug does to the body, how the drug affects the body. And that's how it basically affects diseases. So pharmacokinetics, what the body does to the drug, how it absorbs it, distributes it, metabolizes it, and excretes it. Pharmacodynamics is what the drug does to the body, what effect it has on it. Just to frame this in an example, and then I will move on, we've been talking about albuterol, right? Albuterol is a pharmacologic agent that we give to patients that are having asthma exacerbations or bronchospasm to try to relax the bronchial smooth muscles so they can breathe, right? The pharmacodynamics of albuterol is that it binds to beta adrenergic receptors in the bronchial smooth muscle and causes bronchodilation. The pharmacokinetics of albuterol is how rapidly it is absorbed from the airways, how it is distributed in the body, and how the body breaks it down for excretion. So that's the difference between pharmacokinetics and pharmacodynamics. And what we're talking about right now is pharmacokinetics, what the body does to the drug. And bioavailability is a really important term in the world of pharmacokinetics. Like I said, is probably the most important term of this whole discussion because, drum roll, bioavailability is defined as the fraction of drug that reaches circulation in a form that is ready to engage in a biological response. In other words, a drug has to be bioavailable to be able to do anything. So we're really interested in how much of a drug actually reaches circulation in a bioavailable form, in a form available to do anything. If a medication is not bioavailable, it's not going to have any effect. And there are some cases where so much happens to the drug by way of absorption, distribution, and metabolism that a very small fraction of what was originally administered actually reaches circulation in a form that is ready to engage in a biologic response. The second bullet point here says it. If a drug reaches circulation in a form that is not bioavailable, it just can't do anything. So bioavailability, critically important concept. It means the drug is in circulation, in plasma, and now it can act. Bioavailability is influenced by so many things, and we're just going to briefly tiptoe through the most important one. So let's see what the slide says. It's influenced by route of administration for sure, GI motility, drug-drug interactions, absorption, metabolism, good grief, protein and tissue binding, and finally how it is eliminated. All of this stuff influences how much drug is in circulation, free to engage in a biologic response. So let's look at each one of these things in a little bit of detail. First one, route of administration. Obviously, the lesser of number of roadblocks to circulation, the greater the bioavailability is going to be. I mean, keeping in mind that a drug is bioavailable if it reaches circulation in an unmetabolized form, then obviously if you give the drug intravenously, you're putting it directly into the blood. There's no barriers. There's nothing it has to get through to get there. You start an IV, you push the drug in it, and the drug is immediately dumped into the patient's circulation. No roadblocks. So obviously an IV drug is going to have the greatest amount of bioavailability relative to how much of it you administered. If you push 2 milligrams of Dilaudid IV, then pretty much 2 milligrams of it is going to get into the patient's blood in an unmetabolized form. On the other hand, if you inject something, so we have intramuscular injection, that's the next bullet point here. Intramuscular injection has a little bit of roadblock to get through. You inject the drug into the muscle. Now it has to be absorbed from muscle tissue into the vasculature of the muscle. There's a lot of blood vessels in muscle. Muscle is highly vascular. So if you deposit medication into a muscle, most of it will get absorbed directly into circulation. So while intramuscular injection isn't quite as direct as IV, it's like the second most direct route. So there's not a lot of roadblock there, but there's a little bit. If you inject something intramuscularly, generally speaking, just a little bit less of it will get into circulation. 2 milligrams of IM Dilaudid is probably going to be just a little bit less effective than 2 milligrams of IV Dilaudid because just a little bit less of it is going to get into circulation, assuming all other things are normal. Your handout doesn't say it here, but sub-Q injection is another option. And sub-Q is a little bit less efficient than IM because there's not as much vasculature in fatty tissue. So if you inject something into somebody's fat, it's not going to be as absorbed as directly because there are less blood vessels for it to go into. Some of it is going to break down in fat or even bind to fat before it even gets into the blood vessels. And then PO, finally, when you administer something PO, it's got to go through quite a bit to get to circulation in an unmetabolized form. When you take a drug orally, the first thing it has to do is get through your salivary enzymes. You know, there's amylase and lipase and who knows what else in saliva. Then it goes down into the stomach, and you have several digestive enzymes in the stomach. You have the acidic environment of the stomach, so the drug has to get through all of that. Then it has to survive being absorbed through the wall of the gut, to the wall of the intestinal epithelial cells. And then once it gets through that and finally gets into circulation, it's going to wind up in hepatic portal circulation. So it's going to be cycled through the liver before it even gets into general arterial circulation. And the liver is the master metabolism organ. So a PO drug goes through an awful lot before it gets to circulation. And that's not always a bad thing. I mean, that's fine. Drugs that are designed for PO administration, we know this. I mean, it's why you often have to take a higher dose of a thing orally to get the same effect as you would get if it was administered intravenously, because it's just going to get broken down a lot and it goes through a lot before it ever actually gets into circulation. For example, if you're trying to get pain relief with morphine, you give somebody a couple milligrams IV, 1, 2, 4, something like that. But in order for them to get any pain relief from oral morphine, you're typically giving like much more of it orally, 30, 40, extended release 50 milligrams, because by the time it goes through all of these roadblocks in the intestinal tract and intestinal mucosa, less of it is going to reach circulation in an unmetabolized form, free to engage in a biologic response. It doesn't necessarily mean that more roadblocks are bad. Sometimes we want that because it sort of delays and prolongs the administration. So I'm not suggesting that faster is always better, just that they're all different and they all present their own roadblocks that we have to consider. So that's one thing. And then there's several routes of administration that aren't presented here, but I hope you'll extrapolate the same principles when you think about them. There's transdermal administration of some medications. There are things that we apply as patches. Sometimes we apply pain management as patches, like fentanyl in the form of Duragesic. Hormones are placed as patches. There are several hormone therapies for women. There's a patch of Alzheimer's medication. There are nitroglycerin patches. I mean, there's lots of things that we apply transdermally that are absorbed through the skin and distributed into circulation. And of course, they have their own barriers, right? And then there are medications that we administer rectally. There are medications. Well, yeah, that's enough of an example. Just, take the principle. Just because it's not listed here on the slide specifically, the thing that you want to remember is every time you administer a medication, unless you give it intravenously, it typically has to go through something to get to circulation in an unmetabolized form. And at the end of the day, all that matters is how much of that medication reaches circulation in an unmetabolized form, free to engage in a biologic response. Another one is GI motility. And GI motility, like your slide says, can have some really unpredictable effects. You just can't predict it. All you can do is consider that GI motility will have some impact. Like the slide says, in some cases, increased motility will increase absorption, and in other cases, increased motility will decrease absorption. And the reason for that is the gut, classically is supposed to experience peristalsis. The gut is normally expected to have a certain pH, a certain concentration of digestive enzymes at different times in the eating cycle, and then it peristalses at a predictable rate to the extent that you're supposed to have one bowel movement every day, right? That's the theory. Oh, that it should only be that way all the time, but that's the theory. So when drugs are designed for PO administration, they're designed with the expectation that they will endure certain enzymatic degradation, they will endure certain acidification, and that they will be in these environments for a certain amount of predictable time. So anything that changes the amount of time the drug is in the gut can impact absorption. If you have accelerated motility, then things are moving through the gut too fast. That means there's less exposure to those digestive enzymes, less exposure to acid, and less transit time, like it doesn't stay at the absorptive sites as long. Sometimes that'll increase absorption, and sometimes it'll decrease it. In other cases, if you have increased GI motility. I'm trying to follow along with your slide here. Sometimes the fact that a drug isn't broken down as much as expected because it doesn't have as much exposure to salivary enzymes and acid, that will increase its level of absorption. So what I'm trying to say here, and I think I'm not doing it very artfully, is that sometimes when you leave a drug in the gut too long, it'll increase absorption, and sometimes when you leave it in there too long, it'll decrease it because it gets too broken down to be absorbed in any useful form. So the takeaway message from this slide is changes in motility, either up or down, will impact absorption either up or down, and impacting absorption ultimately impacts bioavailability. You just can't make any prediction. You can't know. And that's what some of the examples here are meant to show you. Increased GI motility, like somebody who has diarrhea, for instance, like maybe a little gastroenteritis, if they're on lithium, that's actually going to increase their absorption of lithium. On the other hand, increased GI motility, somebody's got a little GI thing going on, little jet-propelled diarrhea. If they're on digoxin, it'll probably decrease absorption. And you just have to account for this when you're considering, how well a drug is doing what it's doing. There are sometimes interactions that occur in the gut that can, again, either decrease or increase absorption. So let's see what your slide says. Some drugs require an acidic environment for absorption, which is good because the gut is acidic, right? We make a lot of acid in the gut, and the pH of the gut is normally somewhere between a pH of 4 and 5. So if you have a drug that requires an acidic environment, if the patient is also taking medication that raises the pH, then this can significantly affect absorption. So the example that's given here are tetracyclines and ketoconazole. So the tetracycline family of antibiotics, these are used for lots of different things still. They're used for acne. They're used a lot of times for odd, weird conditions, some STDs, some weird infectious diseases, but we still use them plenty. And then, of course, ketoconazole is used for fungal infection. They really need an acidic environment in the gut for maximal absorption. Well, there's a whole family of medications that raise the pH of the gut, and of course, when you raise the pH, you decrease the acidity, right? The lower the pH, the more acid you are. So maybe this patient maybe a patient has acne, and they're finally going to go on medication for it, and they're going to take a tetracycline antibiotic. And they failed to mention that they're also taking a proton pump inhibitor for GERD. They have reflux, they're taking Protonics every day. Well, that Protonics really changes the pH of the gut. It really raises it and makes it less acidic. This patient is not going to absorb that tetracycline antibiotic nearly as well, and it's not going to work as well because of this interaction. Same thing with the ketoconazole. If the patient has a fungal infection, when they take ketoconazole, if they're also on something like Zantac or Tagamet or Axid or Protonic or Pepcid or Nexium, those drugs that raise the pH of the gut will really interfere with it. Other drugs that can really interfere with GI absorption are listed in the second bullet point, like antacids, like things like over-the-counter Tums and stuff like that. Those drugs work by binding stomach acid. That's what they do. So if you have a patient who's taking a bunch of antacids, and they're also then given a drug that needs an acidic environment for absorption, again, it's going to change the absorption. Bile acid binding drugs, we'll talk about them more in a couple weeks. I mean, these aren't used as commonly anymore, so you're less likely to see it. But there are times when the bile acid binder called Welchol is used. Mostly it's used for people that have chronic diarrhea syndromes because it really is a binder. But it also binds other medications. Bile acid binding drugs are like little magnets. They sit in the gut and suck everything around them onto it like a magnet. So if the patient is taking other medications at the same time as they take a bile acid binder, that bile acid binder, like a magnet, is going to suck up those drugs, keep them from being absorbed, and they just get tumbled down the rest of the intestine and injected out the other end. So again, these are just some examples of roadblocks or things that can interfere with bioavailability. Because if you take a drug and you take it orally and it gets deposited in a GI environment that does not favor absorption, then it can't be absorbed, it doesn't ultimately wind up in circulation, and ultimately you don't have bioavailable amount of that drug. It can't engage in a biologic response. What else do we have here? Interactions that occur in the gut. So tetracycline, phenytoin, theophylline. Okay, these are just some examples of drugs that can be huge impairment of absorption when they're given with things that we just were talking about that interfere with absorption. And then some drugs alter motility. So metoclopramide, you might know this as Reglon. Cisapride is, oh my goodness, what's the name of that drug? Propulsid. Propulsid, and you don't see as much of that anymore, but metoclopramide you do see used. That metoclopramide speeds up motility of the gut, as does cisapride. Opiates and anticholinergic medications markedly slow down GI motility. It's why opiates and anticholinergics are notorious for causing constipation. So the bottom line is there's a whole series of interactions that occur in the gut. Some of them can happen because certain medications will change the pH of the gut. And then other things can happen where drugs alter the motility of the gut. Either way, they can all interfere with absorption, which means decreased bioavailability, which means there's not as much drug active to engage in a biologic response. And remember, in terms of bioavailability, at the end of the road, all that really matters is that a drug is free to engage in a biologic response. Interactions that occur in serum. Okay, so now this can affect all medications. If you give a drug orally and it makes it through everything else and it winds up in serum, now you have to consider interactions that occur in serum. Conversely, even if you don't take it orally, if you give a drug IV or give it any other way where it just has to get absorbed in a blood vessel like intramuscularly, once the drug is in serum, there are interactions that occur there also that we have to consider. So let's see what this slide says. Interactions that occur in serum. Most drugs are most biologically active in the non-bound form. And this is true. Just, in general terms, if a drug is bound to something in serum, it's not free to engage in a biologic response. Most of the time when a drug is bound to something, it's bound to protein. There are some circumstances where drugs are bound to fat, and then they're not free either, but most of the time drugs are bound to protein. When they're bound, they are not free to engage in a biologic response. So, if the patient is taking two medications at the same time, and that doesn't necessarily mean like at precisely the same time, but it means in the same like therapeutic interaction. So a patient might be taking one drug once a day every morning at 10 a.m. and another drug, BID, at 8 a.m. and 8 p.m. So you're not necessarily giving them at precisely the same time, but you're giving them to the same patient in the same therapeutic interaction. Co-administration of two or more drugs that are normally highly protein-bound will result in greater activity of one or more of both drugs. For example, co-administration of Coumadin and ibuprofen will exaggerate the effects of Coumadin. So again, think about that for a minute. If you're taking drugs that are normally highly protein-bound, and there are a lot of medications that we know that pharmacologists know as soon as you put the drug in the body, it's going to bind largely to protein, and that the protein-bound piece will be inactive. So it's dosed based on that expectation. For instance, Coumadin. Coumadin is 97% protein-bound. We know that when you give somebody Coumadin, whatever dose you give, 97% of it predictably will bind to protein in serum, and only 3% will be unbound and therefore free to engage in a biologic response. So if you give somebody 10 milligrams of Coumadin, we know that 9.7 of those milligrams is going to bind to protein and not be free, and that 3% will be free to engage in a response. This is just how it works in the body, and why, I don't know, but that's just the way it is. So the way it typically works is a patient's not on any other drug, and then you put them on Coumadin, you give them 10 milligrams, 9.7 will bind to protein and not do anything in the body, and 0.3 milligrams will have its response. 0.3 milligrams will go on to interfere with activation of prothrombin and interfere with clotting, right? And then that 0.3 milligrams will go through the typical pharmacokinetic processes. It will be absorbed, distributed, metabolized, and excreted. When that 0.3 milligrams is excreted from the body, the 9.7 milligrams remaining that's bound to protein, the body will liberate 3% of it. So protein bound is sort of like a storage form where the body feeds off little bits at a time. So that however much Coumadin is in the body at any given point, about 3% of it will be unbound and active, and 97% of it will be bound to protein and inactive. And if the patient's just taking Coumadin and nothing else, it's pretty easy to predict it, and we can treat them therapeutically, and it's fine. This isn't a big deal because we know what's going on. The problem is when you give the patient another drug that is also highly protein bound. Because if you give another drug that is highly protein bound, now you have two medications competing for a limited number of protein binding sites in the body. And I think that takes us to the next slide. Yep. So if you have two drugs that are competing for the same protein binding sites, one of them is going to win. The most common protein to which drugs bind is albumin. Like your slide says, there are others there, but albumin is the most common. And again, the portion of a drug that is bound to protein is considered stored or biologically inactive, while the portion of the drug that is not bound to protein is considered free and capable of engaging in a biologic response. So, the percentage of protein binding remains constant. When two drugs that are highly protein bound are given simultaneously, the one with the lesser affinity for protein will be more abundant in its free form. So here's the example that I've started to give you a little bit earlier. We know that Coumadin is 97% protein bound. So at any given point in time when you give somebody Coumadin, you expect that however much is in the body, 97% will be bound and inactive, and 3% will be free and biologically active and interfering with clotting. Perfect. But then if you give another drug that is also protein bound, now that drug wants to bind to protein too. So there's going to be competition for binding to the limited amount of protein available. And albumin is the most commonly used one, so albumin is a good marker. Now, like say, I think the example I gave you somewhere in this slide set was ibuprofen, good old-fashioned ibuprofen, which so many of us take routinely for a headache. If you're taking Coumadin every day, same dose, and everything's fine, your INR is therapeutic, and life is good, and then you get like a 3-day headache, and you find yourself taking ibuprofen like a couple times a day for a couple of days. Well, ibuprofen is also very highly protein bound. I believe I read 99% protein bound. So the expectation is when you take ibuprofen, the overwhelming majority of the dose is going to bind to protein. And that's fine if you're just taking ibuprofen. But now if you've got Coumadin and ibuprofen competing for the same amount of albumin, the same amount of protein, the drug with the stronger affinity for the protein is going to win. It's going to win the binding sites. And in this case of this example, ibuprofen has the stronger affinity. It's a stronger magnet for protein. So if you introduce ibuprofen, it's going to kick Coumadin off the binding sites, and then more Coumadin is unbound and free to engage in a biologic response. That means that the blockade of clotting is going to become exaggerated, and the patient's going to start bleeding. And this is why, like, Coumadin is notorious, and any of you who have had patients on it, I'm sure you can empathize here. Coumadin is notorious for, like, everything in the world interacts with it. And it's just so hard to keep it regulated, especially if the patient is on other drug therapy. It's like almost everything in the world can interfere with the action of Coumadin. The reason for that is that Coumadin is presumed to be highly protein bound at 97%, but to not have an especially strong affinity. It's a weak binding property. So if there's nothing else in the way, everything's fine. But if you give anything else that wants to bind to protein, it's going to kick the Coumadin off the protein binding sites really easily, and then suddenly you have a bunch of protein, or you have a bunch of Coumadin circulating that's not bound to protein and is biologically active, and the end result is too much clotting. So this is just an example of an important interaction that occurs in serum. And Coumadin is a really dramatic one. There are lots of other considerations here. If the patient has low protein, if they're hypoalbuminemic, then any drug that is largely protein bound is suddenly going to become more free to engage in a biologic response. So, like, for instance, let me go back to the example of Coumadin, but forget giving any other drugs. I mean, the patient might just be on Coumadin and nothing else, but maybe the patient is, like, nutritionally compromised. And instead of a normal albumin of 4, maybe this patient only has an albumin of 2.5. Well, this patient has like almost just half as much protein as we normally anticipate. That means there's little more than half as many protein binding sites than we expected. That means that not nearly as much of that Coumadin is going to have any protein to bind to. So when we give a patient with an albumin of only 2.5 Coumadin, a whole lot less than 97% of that Coumadin is going to be bound to protein. There's just not that much protein there. So having a low protein can really exaggerate the effects of drugs, because any drug that is normally largely bound to protein will be abundant in an unbound bioavailable form much more readily in a patient who's hypoalbuminemic. So that's an important piece of that interaction. Anytime you have less protein binding than you would normally expect, whether it's because the patient's albumin is just low or because the patient is on other medication that binds to albumin, the end result is going to be more bioavailable drug and more biological activity. So it's something to consider. If somebody's drugs seem to be like hitting them really hard, maybe it's because their albumin is low, or maybe it's because they're taking other drugs that also are protein bound. What else do we have here? Let's see. Absorption refers to the ability of a drug to reach circulation, cross the membrane at its target cell. Yes, circulation is a key factor. So I've talked about this a little bit. But the other thing we have to consider in terms of circulation is if you are injecting a drug, or even for that matter, taking a drug orally, whether you inject it IM, sub-Q, apply it transdermally, insert it in the rectum, or take it PO, the very last step of absorption is that that drug has to cross blood vessels and get into the vasculature, right? I mean, no matter how you start out, the last step is that a drug has to get absorbed into blood vessels because it's not biologically active unless it reaches circulation in an unmetabolized form. The circulation itself is a key factor. If the area is hypoperfused or the vasculature is impaired, this is going to block the way that the drug can be absorbed. So, okay, yes, I won't read this to you. You can read that. But here's the way this plays out. Suppose somebody has had poorly controlled diabetes for a really long time, or poorly controlled hypertension for a really long time, or just peripheral vascular disease. Something has happened to really mess up those patients' blood vessels. So you know their capillaries are a mess. Probably half their capillaries have like sort of sclerosed and they're just not working well. Some of them have like flamed out and hemorrhaged for whatever reason. And really uncontrolled hypertension or long-term hypertension is a good example. Just all of the peripheral capillaries, like they're all sclerotic and not working well. Their circulation stinks. So if you inject a medication or even take orally a medication and rely on the fact that ultimately it's going to be absorbed into the vasculature, how well can it be absorbed in somebody whose capillaries are all screwed up because for the last 30 or 40 years their hypertension has not been well controlled? It's not going to be absorbed at all. So you might even inject a drug intramuscularly and you think that it's going to get sucked right into blood vessels, and then the drug has no effect. One of the reasons may be that their blood vessels are so messed up that nothing can get absorbed. This is why sometimes, like, have you ever had a little old lady or man patient who barely seems to have like 90 pounds of body weight on them, and you think that if you just give them the smallest amount of drug, it's going to kill them over. And then you inject something and it doesn't seem to make any difference at all. And you're like, what's going on here? They have no body weight. What's going on is that you injected the drug, or even administered orally the drug, into a body part that has not good circulation. And without good circulation, the drug just can't get absorbed into it. By the same token, you know, to flip that around, maybe you've got like a really big, muscular, you know, young adult, real muscular person. And they're real, you know, they're like tall and big and well developed, and you think, ooh, they're going to need a higher dose. And then you give them like some smaller dose of something and it has a huge effect. Why? Because their vasculature is so well developed that whatever you gave them, whether you injected it or administered it orally or transdermally or whatever you did, their vasculature is so good and so solid, and their little arterioles and capillaries are so dilated and well perfused that all of the drug gets absorbed in there. And that is why sometimes you give a dose of a drug to a young, healthy, strapping person, and it's really effective. And then you give that same dose to, you know, like an older person with a bunch of chronicities, and it doesn't make any difference at all. It's because, body weight aside, the drug has to be absorbed into the vasculature for it to do any good. And if the vasculature stinks, the drug just won't go in there. And that's that. So I think that brings us to the end of this first slide set. I know I've thrown a lot of different seemingly unrelated things at you here in this first week. It's not an especially long slide set. What are we at? Just like an hour and 10 minutes, because I wanted you to be able to take the time and sit down and really think about this stuff. Sometimes pause a thing or listen to it again, listen to it a few times over. Use the links that are provided, like the external links that will sometimes just give you another way to try to understand some of the things I've said here. But I really do want you to feel like you have an understanding of this stuff before moving forward. So that's my goal. I hope it was helpful. If you have any questions about anything, of course, I would always encourage, just the best way to learn is if you have questions about something I've said in this slide set, go to your books, go to your references, and see if you can figure it out. But if you can't, by all means, drop an email or call me or something. I'm really happy to try to explain anything that might have seemed a bit ambiguous. And that's all I know. I will talk with you next week.